871 in Medic 6. You're seeing a 74-year-old male, shortness of breath.
Bariatrics is the term used to describe a branch of medicine that deals with the causes, prevention, and treatment of obesity.
I like these. I want some of these.
The most important thing for EMS responders to appreciate about bariatric patients is that they exist. They have to understand their special needs, they have to understand the pathophysiologies associated with the disease, and you have to understand the special treatment modalities that are required to care for them.
God, I'm not feeling good, Joe.
Yeah?
Yeah.
What's wrong?
The cramps are getting worse.
Yeah?
Yeah.
Morbidly obese patients often suffer from serious illnesses and diseases that eventually lead to death. The most common obesity-related health risks include hypertension, diabetes, stroke, coronary artery disease, osteoarthritis, non-alcoholic hepatitis, gallbladder or kidney disease, and some cancers. Psychiatric issues include depression and loss of self-esteem.
I feel right. Something's wrong. It hurts.
Okay.
As an EMS provider, your main concern will be with patients that are morbidly obese. These patients are 400 to 1,000 pounds and present many challenges in the pre-hospital environment, not only because of their size, but for treatment considerations as well.
She's dizzy, her stomach hurts, she's recently had bariatric surgery.
There are often a multitude of reasons for a patient's obesity and their corresponding health conditions. Reserve your judgments. As with any patient, they deserve your care and respect. Be sensitive and professional with your remarks and attitude. Obesity doesn't impair your patient's hearing or their feelings.
What doesn't feel right?
Oh, I've been cramping for a couple of days, and when I got up over there, I got really lightheaded.
Bariatric patients have a number of conditions and diseases that complicate their care. Probably most important is the increase in diabetes as a result of their obesity. And a lot of EMS providers, medics alike, tend to focus on that aspect because when you look at an obese patient, you think it's some type of nutritional problem. But the other two conditions that are real problematic for them, one is heart failure. It kind of comes with the territory. There's a whole pathophysiology that's involved around obesity and the development of heart failure. And the other is respiratory failure. And those are probably two problems that are more pressing for an obese patient in a pre-hospital setting than perhaps their nutritional status.
Obese patients are 10 times more likely to have diabetes and kidney failure and are 6 times more likely to develop chronic hypertension. Hypertension affects the kidneys, heart, lungs, and brain and increases the risk of stroke and kidney failure. When caring for an obese patient, you can assume that their weight is placing excessive demands on their heart and lungs. They will have difficulty breathing due to the increase in pressure and restrictions on their lungs. As with any patient, first focus on the ABCs. When obtaining a blood pressure, make sure that the cuff is big enough and fits properly. An improper fitting cuff will result in an abnormally high reading. Administer oxygen and address any clinical symptoms you find. Obtain a blood glucose reading and continue assessments based on the chief complaint.
Pete's going to hook you up to our cardiac monitors. We can get a look at what your heart's doing.
Assessing vital signs of a morbidly obese patient can be problematic due to excess adipose tissue. The use of pulse oximetry may give you the most reliable reading. Try to obtain an accurate as possible baseline so you can monitor and reassess for any trends in vital signs. When delivering care, understand that you may not be able to rely on your usual assessment techniques or equipment. Landmarks may be difficult to detect, and increased fat deposits may prevent the ECG monitor from detecting the electrical signals. P waves are often difficult to distinguish with obese patients. If this is the case, pay attention to ventricular rhythms.
The list of modifications and treatments is long. One of the problems with the body mass. Often EKGs are not obtainable, or the complexes are very small. You have to do some changes on your machine to get a readable EKG, if you can get one at all.
Oh, yeah.
Over 80% of those with type 2 diabetes are overweight. An obese patient is 3 times more likely to develop diabetes than an average weighing individual. An increase of fatty acid in the bloodstream inhibits the use of glucose and causes insulin resistance. There are life-threatening conditions associated with diabetes for any patient. If your patient is diabetic, ask them about the management of their diabetes.
There's the development of a rare condition that's becoming more common, the development of diabetes in the bariatric population, and that is patients with hyperosmolar, non-ketotic coma, HHNK or HHNC, and the EMS provider should learn about this disease because it doesn't present like the typical diabetic emergency with Kussmaul's respiration, the ketonic breath, and those type of indicators that EMS providers have come to depend on in the past, yet they still have incredibly high blood glucoses, which can be life-threatening.
Many patients have turned to bariatric surgery as a long-term weight loss solution and to reduce the associated health risks due to excess weight.
It's important that EMS providers learn about bariatric surgeries, and particularly complications of bariatric surgeries. Many of these people have surgical problems after the fact, and they're going to be called to those homes to take care of those patients.
Understanding the basics of bariatric surgery and post-operative concerns is helpful in providing patient care. Serious, life-threatening complications from bariatric surgery are not common, but can include pulmonary embolism, anastomotic leaks, and respiratory failure. If your patient has recently had weight loss surgery, assess for sustained tachycardia, dyspnea, severe abdominal pain, fever, rigors, and hypotension. Additional symptoms to inquire about include nausea, vomiting, increasing abdominal pain, back pain, pelvic pressure, diarrhea, dizziness, hiccups, and restlessness. Assess for signs of infection and symptoms of pneumonia.
Okay.
We'll take you up to the hospital, okay?
Okay.
Skin vitals are normal. Her pupils are pearl at 4. She's been running a low-grade fever, about 99 degrees for the last couple days. And the only other thing is she has left lower quadrant abdominal pain on palpation.
Depending on their size, mobility, and the number of responders available, the management of a morbidly obese patient often requires ingenuity and creative problem solving. If your department does not have bariatric equipment, mutual aid providers may be able to assist with large capacity gurneys or transport vehicles. It is also helpful to identify in advance the patients in your jurisdiction that will have special needs. Pre-planning with them and recommending modifications to their living environment will allow you to provide efficient and appropriate care when needed.
Probably the simplest way that EMS could improve its capabilities, its function in the treatment of these patients, is appreciating this as a team approach. You need to get all the players in the same room to discuss the problem, and that there are resources out there that many of them haven't even considered tapping. For example, almost every community has a bariatric specialist, somebody who does bariatric surgeries and so forth. They understand the patient population, the problems that their patients have. They can give a great deal of insight. And it's everything from having dispatchers who have at the bottom of their screen what they call bolos, be on the lookout. Well, they can put special alerts that at this address there's a known patient who has special needs, to knowing where those people live in the community and getting that information from these bariatric specialists. Sometimes they're very forthcoming with where their patients are.
Other plans might include bringing in definitive care to the patient, possibly eliminating the need to transport.
There's not different treatment modalities for geriatric patients per se, as much as there's different ways to apply those treatment modalities and perhaps different situations or circumstances for applying those treatment modalities that an EMT or a paramedic might need to think a little bit out of the box in order to consider them and apply them. So for example, one of the most common problems with bariatric patients is when you lie them flat, supine, the weight of their abdomen presses up against their lungs, and it causes a functional compression of the lungs, loss of capacity, and they quickly become hypoxic.
When administering IVs, you may need to modify your technique or placement. Sometimes applying heat or a light tapping over vessels will improve your success. Remember, any weight-based medications will need to be adjusted for size. Consult with medical control for appropriate dosage and treatments.
IVs is one of the classic problems because of the mass. It takes a longer needle to access an IV. So to carry 2.5-inch angios is not real common practice. A lot of medics use shorter IVs. But for the bariatric population, you have to carry these special tools to be able to care for them properly. Same thing with intramuscular injections. The needles, you need to have longer needles in order to be able to penetrate and get to the muscle below.
Because of the increased demands on the heart, you'll often find morbidly obese patients to be hypertensive. This is diagnostically challenging. Vital sign readings may indicate hypoperfusion, but this could be a normal finding for this patient. In addition, heart sounds are almost impossible to hear through the thicker chest wall. Life-saving interventions can be problematic. Management of cardiac arrest will require frequent rotation of personnel. The patient's size and the thickness of the chest wall make compressions difficult and shocks less effective. Anticipate difficult airways. The anatomy is often distorted due to excess tissue. Customary landmarks will be hard to identify. You can dramatically improve ventilation by placing them in an upright or high Fowler's position. Ventilating and intubation is best done with the patient upright. Capnography, or an end-tidal carbon dioxide detector, is the gold standard in confirming tube placement. Breath sounds will be difficult to auscultate. Due to increases in gastric secretions, you should prepare for suctioning. The insertion of nasogastric tubes can be helpful in these patients to help reduce the possibility of gastric distension, regurgitation, and resultant aspiration. Remember, chest expansion is restricted in these patients, and the soft tissues of the airway collapse easily. Consider the use of a BVM or CPAP. If a morbidly obese patient is not ambulatory, moving them can be very problematic. Don't risk injury to your crew or your patient. Make sure you have enough manpower and the right equipment. It can take 10 or more people to safely move an 800-pound patient. Most gurneys are rated to 600 pounds in the down position. Don't attempt to modify or use a gurney if your patient exceeds the weight limitations. Call for more resources. When transporting, try to make your patient as comfortable as possible and elevate their head slightly. Most morbidly obese patients cannot tolerate laying flat for any extended amount of time.
Well, the main treatment challenges for bariatric patients at first blush would be moving the patient. So for the pre-hospital provider, it becomes quite a unique challenge in many cases. And EMS providers, having somewhat the same mentality as a lot of the Marines, adapt and overcome, have developed some pretty unique ways of dealing with moving people, large people, out of some very difficult situations.
Much like vehicle extrication, it may be necessary to remove doors, windows, or walls in order to get your patient to definitive care. Pre-planning is essential for your safety and your patient. Key questions include, do we have the appropriate manpower available? How can we best care for and respect this patient's needs? Do we have the proper equipment? Do we need specialized resources like trucks, ramps, cranes, airbags, construction equipment, or specialized crews? Knowing where to obtain specialized resources is critical.
You got him in. How you doing, bud? How's your belly doing?
Okay, let me know if you get dizzy, okay? I feel like you're gonna fall.
I need help up.
Remember, these patients are sensitive to their condition. They may be in crisis. They may have delayed seeking help for fear of insensitive handling or humiliation. It is important that you are non-judgmental, expressing care and concern. Ask for their current weight or approximate it as closely as you can. This is important for your safety and the crew, as well as to make sure your equipment meets the size and weight requirements. Involve the patient in your planning process and tactfully explain what your concerns or challenges are in the environment.
Probably the greatest challenge to providers is that operational aspect. It's the getting the people together that you need. In some circumstances, you need to take down walls, and you need people who have experience with urban search and rescue, who understand what a load-bearing wall is, people who can get community resources that may be necessary to the scene. Sometimes these things are done very much on the moment, and the result is the chaos that occurs. Trying to have a plan on how to respond to these special needs patients and then to execute that plan. That's the biggest challenge that most EMS systems have. And that's probably coupled with financial constraints to prevent them from getting things that they need, like bariatric ambulances, and perhaps managerial constraints, for example, trying to get mutual aid agreements with other organizations who may have those resources, like a bariatric ambulance, to come to their scene in a timely fashion.
1, 2, 3.
You okay? Yeah. All right, we're gonna start taking you out in the ambulance.
Obese patients are often the targets of bias and weight stigma. These are the negative attitudes of others regarding their condition. It's important to be aware of your own biases or assumptions you make regarding these individuals. You can make a difference by developing empathy and by working to address their needs and their concerns. Understanding the unique and diverse challenges of morbid obesity, the related health concerns, and necessary treatment considerations of these patients will enable you to anticipate and deliver the best care possible.
To become educated about the bariatric patient, there is the traditional routes. There are the EMS magazines and video journals and things of that nature, but probably the easiest way is to reach out to their own community. Most of these bariatric centers have outreach groups. Many of them have support groups. Meet with the people, meet with the patients, come to know what's important to them, and find out what their needs are and what their concerns are. It doesn't necessarily take an in-service or anything like that. Sometimes it just means everybody getting together in the truck and going down to the hospital in the evening when the bariatric group is meeting to discuss their issues and introducing themselves and letting the community know that they're there for them. It can have a huge impact, a positive impact.
Remember, treat these patients as you would any other, with respect and compassion. It's important that your agency is equipped and you are experienced in the management of these patients. Advanced planning and having or identifying additional resources will enable you to be successful in your treatment and transport.
What is most important for an EMS provider to consider when taking care of a bariatric patient is that they're taking care of a patient. Sometimes the operational concerns on a scene, how to load the patient, how to move them, manpower concerns, equipment concerns and all that, you kind of get lost in the technology, and it becomes impersonal. And it's really important to remember that underneath it all there's a person there who is reaching out for your help. And the more positive that person's impression of EMS is, the more likely that individual will seek the help that they need to get better. And that if they have a bad experience with EMS, then they're less likely to call 911 when they truly have emergency, or they'll call it in such a time that it's time sensitive, and then EMS is scrambling to try to be able to meet the patient's needs. So it's really about treating people like people, and we're really good at that. We're real good at taking care of people.